All right, James, it looks like we've got a good contingent online. I'm looking and it looks like we have our fellows are present and accounted for in all the major locations. And so I think you can go ahead and get started.
Okay, so I do just because I'm speaking, I have a drink. So I will just say neither Diet Coke nor McDonald's have paid me for product placement into my presentation today. So
noted.
it's a dyspnea. There's something in the air. I put this is something I find very commonly in the supportive care clinic managing oncology patients. I thought it was important, and I hope you guys get something from it. I spent a lot of time on the internet searching someone else's presentation to steal, so a lot of time went into this, but here we go. I have no financial disclosures. I'd love some. What I'd hope people take away from it today is what is dyspnea and its prevalence, what aspects are reversible as compared to treating symptoms, describe the various measures available to detect or dyspnea, and then describe various measures available to treat symptoms. So dyspnea, so loosely translated from the Greek, it means bad breathing. It's a sensation of shortness of breath, so it's subjective. It differs from respiratory distress, or other words, or ventilatory status, or things that are observable. Often underreported and underdetected. I hope you like this fact. You'll be hearing it again, but also I bring it up. Just about every source I went to, I could not get 3 paragraphs about them talking about how patients don't seem to bring it up and we don't seem to look for it or recognize the severity of it. So according to the American Thoracic Society, it's a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary. Or according to Lewis, who is a patient of mine I adored and unfortunately passed, he's a stage 4 lung cancer patient with COPD. And Lewis used to say that dyspnea, it's the thing I grapple with and fear every waking moment. So no specific reference for this, but I still found this interesting. This is just a colleague from the UK who came over on sabbatical, and he said the hospices there always document eupnea or normal breathing, which he thinks is to act as a key to remind them to review for dyspnea. So it's subjective. It has multiple inputs: environmental, physiologic, psychologic. We don't have a lab test. We don't have a measure. We don't have the dyspnea meter. And numbers vary of what is. So not one number means dyspnea for everybody. So the classic example are Navy SEALs or Navy divers. They can hold their breath for a huge number of minutes. Their labs or their SAT numbers seem to change, and they're perfectly okay. And they'll tell you, okay, they'll turn around and they'll start a computer or do a tic-tac-toe or something while they're doing this. So again, respiratory dysfunction, ventilation status, other similar terms are the things more likely to be able to describe things that are observed or measured. So because dyspnea is subjective, again, I told you so, it's often underreported, underrecognized. So this has to be said. I still encounter this. I still educate people in the hospital setting, especially sometimes our ER colleagues. And even after Minneapolis, we still have to educate people. If you can say, I can't breathe, you can breathe, is horrendously wrong. Absolutely horrendously wrong, both in ventilatory status, but definitely in somebody who has the feeling that they can't breathe or dyspnea. The fact that they're speaking does not mean that they're having great distress on their status. So the perfunctory physiology slide. So there's some multiple inputs that go into the brain or how we perceive breathing. You can think about anywhere in this pathway that there would be dysfunction, and then that would cause in turn the sensation of a difficulty breathing mechanically, or the patient senses it and interprets it directly as dyspnea. Whether you have inability to expand your chest wall, or you feel something's obstructing or not moving in your upper airway, or you have different metabolic sensors telling you your CO2 or your oxygen balance in your blood is off, many things, but these all go up and get processed. But then there's a part also where the patient processes it and how they sort of gets interpreted for them and what it means for them. So I throw this couple slides in because it's to emphasize another point. So again, this is World Organization's what is palliative care and its approach to improve the quality of life, but I highlighted and their families on purpose. Okay, sorry about that. It's sticky mouse. And then what is palliative care? This is CAPC's definition of it, a little bit more simplified, but again, we put into it, mega organizations, we put in that our job is not only to eliminate suffering of the patient, but the family, and that's Dame Cicely Saunders' enduring contribution to the field among many, was she realized when people's families were taken better, not only was that morally and ethically appropriate, stop suffering, but the patients did better if they saw their families were doing okay, their families were not distressed. So I moved this into the stress carried by patients and the witnesses. So that gentleman on the left, Dr. Rivers is a psychiatrist in military medicine circles. He's famous. He did a lot of psychiatric studies in World War I, but his contribution to military medicine was that having PTSD or other psychiatric disorders from combat or wartime was not a reflection of moral character or not a reflection of your personal courage. Not courage. So they used to stamp on people's charts LMF, and that stood for lack of moral fiber, if they were having PTSD, or then he got rid of that and other things. So next to it, this building's still in existence. It serves another purpose now, but that's Craig Lockhart Hospital in Scotland. And it was a hydropathic hospital before the war. Then the World War I, it was converted to a psychiatric hospital. And the reason I bring this up was that he did a lot of studies, and one of the things he was noticing was, even if it wasn't their wounds or the classic thing of a shell burst or all the horrific things we can think of in wartime being shot, he noticed how many significant number of patients also had horror and psychiatric distress from seeing people in the gas attacks, or essentially seeing people that were subjected to things that the bottom line was that they could not breathe. So there were multiple stories from literature in World War I about people were driven to such insanity or panic at the idea of that they would steal someone else's gas mask, or they would steal the gas mask off if somebody's wounded if theirs wasn't working. Wilfred Owen, who was one of Rivers' patients, as well as Robert Graves and Siegfried Sassoon, other authors from the war. But Wilfred Owen, one of his most famous poems, talked about having to watch somebody dying in a gas attack and they can't breathe, and how that left with them. And then there were just episodes that would people, if their gas mask, they were seeing they were dysfunction, as compared to dealing with the sensations of that, they would turn around and they shot themselves. So he noticed it's a horrible, distressing thing, not only to have shortness of breath or have respiratory distress, but also for people just to witness it. I would not put a photo of somebody suffering for real. This is a posed photo. This was training in World War I, the U.S. Army, but they made sure in their training they had someone that was shown that they didn't have their gas mask, and it was to demonstrate to other people during the training, like, you don't want to be this guy. And the military still does that today. The military will put you in to a chamber that they give something the equivalent of tear gas to subject people to as an extra incentive of, you don't want to go through something like this, before they go into the training on how to put on their gear that requires a gas mask or such stuff in an environment. I went through that training myself. But this one, I feel really, the artist really captured it all. And this is Louis Remaker. He was a Dutch artist that was horrified by what the Germans did, and he did paintings of what he saw around World War I. So these are two gas attack victims. And if you see the gentleman in the foreground, maybe in delirium or status, but obviously distressed. The patient towards the rear has a sensation of choking, and you look at the nurse is trying to do something for him, but obviously distressed that they're suffering and something, and the doctor in the back trying to figure out what to do, or feeling frustration or just a lack of, just for lack of a better word, unpleasantness with this situation, and seeing patients who are distressed like this. So but anyway, just to start back being the slide, take this tour, and many of the benches, and I thought they were for the comfort of people with arthritis and things. And he said, well, that people with shortness of breath with walking, between tuberculosis and recovering from pneumonia, and people who survived gas attacks in the war, many benches were actually bought with the intention it was give somebody shortness of breath a place to rest. And then subsequently, it's been inferred that all the benches were just either for sitting because your joints hurt, or a little bit tired, which I thought was interesting. So this was a colleague of mine, a mentor, Melanie Oblander, who's who I worked with in Lubbock, and I agree with this. You could debate this and be open to debate, but in my opinion, I agree with this, that pain and dyspnea are probably the most distressing symptoms families see, but witnessing dyspnea seems to have an edge on the worst distress the families carry with them. That if a patient passes away and you counseling them 4 months later as part of the hospice benefit, they talk about things that are carrying with them. They can bring up often about how distressed they were to see if their family member was describing or appeared breathless at the end of life. So do you know when you see it? So again, in researching this talk, and again, articles, book talk about how it's underreported, underestimated. There's no perfect scale to measure dyspnea, but you need to like ask or request about it. But you know, as they say, it's common. It shouldn't be hard to find if you go look. Of the 5 most common conditions addressed as end-of-life diagnoses, so HIV, COPD, advanced cancer, renal failure, heart failure. Dyspnea was present in at least 50% or more in each of these groups. It's the only symptom to have been able to have been prevalent in all 5 groups that was more than 50% common. As the trajectory of the illness causes a decline in patients, dyspnea, it gets just more severe, more difficult to treat, more common, and almost even expected or surprising if they don't have it. So in our lung cancer patients, 90% of them will describe the sensation of dyspnea before they pass. So I was just saying before we started, unfortunately, one of my slides was corrupted. It wouldn't translate over, but there is a graph with the different conditions about it. But the thing I was going to point out was that as some symptoms seem to flatten out or their trajectory even decreases a little bit before it's the last couple of weeks of death, dyspnea and then fatigue or drowsiness are the only 2 that actually increase up and keep increasing until about the day of death or when a patient passes away. And of that, even patient groups that are passing away from something that their primary illness is not considered to be lung-based or heart-based, about 60 to 70% of those patients will describe a form of dyspnea within their last month of life. So the dyspnea, so, you know, is it coming, way to break it down real quick, is it coming from hypoxemia or hypercapnia, acidemia, miscellaneous reasons, emotional-ish. I hate the term emotional because I think in our society, depending on who you talk to, it has a negative connotation or a lesser connotation, or why do why don't you just fix it type thing. But as we all know, pain is real, anxiety is real, depression is real, and they're not things that patients want. But I think depending on which group you're talking to, they sometimes look at that as being a lesser thing as compared to if you have like a lung mass. Chronic dyspnea, pretty much add 4-week history to any of the acute dyspneas, and voila, you have a chronic dyspnea. So just briefly, just for the sake, if anybody were to review this presentation again, we've all done hospital rotations or outpatient, depending on our training, or if we're ER, we've seen these in the ER, but the different causes in each of one of these groups. Acidemia. Just to say here, what I tried to explain at end of life is that to families is that is the body's breaking down, and the gas or the change of breathing is just trying to compensate for the acidosis, and that's not quite in the same league as saying the patient isn't oxygenated well or something. Just trying to explain to the patients why they're seeing that and what the process is that's going on. Poor O2 delivery, then the miscellaneous ones that you can see, and then again, emotionless. I'll try to search for a new word, or if somebody wants to send me a word, but pain and anxiety, just either of those 2 as being a reason why somebody has a sensation that they cannot breathe. So poor Dr. Fletcher, what I see in my clinic, and of course you see the world a little bit from your scope. I'm sure my colleagues at Deal ALS are throwing virtual tomatoes at the screen about why I haven't started talking about breathlessness in that condition and such. But the things when I see patients in the clinic, and they telling me this is what's going on. Is it related to their cancer? Is it do they have a superior cadence syndrome? Is it the lung cancer itself, mets to the lungs, carcinomatosis, chest wall invasion, rib fractures? All those things we discuss are examined. Had a lot of patients come in with just walking pneumonia, and they thought that this was a normal part of the chemo treatment, that they didn't feel well, or to have this sensation things. Cachexia, anemia, I'll talk a little bit about that in a minute. Diaphragm dysfunction, just pressing up. So I have a colleague who's an obesity specialist out there in Holland, and he said there are whole talks about just dyspnea in the obese patient. But one of the ideas behind that is that if you have any pressure coming up, so in his case, it's adipose tissue, but in our case, it could be fluid or a mass. Anything that pushes up under the diaphragm can give somebody the sensation that they're breathless. PE, as mentor of mine used to say, if you're not thinking PE, you're not thinking. And metabolic electrolyte issues, which I have. But the therapies, lobectomy, radiation, chemo, cardiomyopathy from the chemo, more common in our pediatric community. And then thanks to it. So, not an uncommon day that my patient with lung cancer has COPD, CHF, asthma, anxiety, pain, especially spiritual pain. A chunk of my patients, a lot of remorse about having been tobacco users, and they have lung cancer now. And then neuromuscular disorders. So the things that I consider in my supportive care clinic, if they're bringing this up, and then I work with the oncologist. So, but the bottom line is, I think with acute dyspnea is that we sort of look at it from the frame of where we come from, so what's causing it. So a little bit just, if you mentioned dyspnea to the nephrologist, it's fluid overload, cardiology, it's CHF or ACS, neuromuscular dysfunction, asthma, pulmonary, how many hours do you have to ask a pulmonologist what I think causes dyspnea, ID, how many bugs can I name? And then the ER, who am I going to call after I tube them for this dyspnea type thing. But we all look at it from a little bit perspective of where we come from and what we see commonly. So it presents everywhere and in the field. So I think, the advice that I have to my fellow is know the things in your field, have a little bit of breath, and then know who to call when it's sort of coming up, you think it's outside of your field or something you can't do. And then I think, the best high yield for the rest of the lecture talking to palliative docs is talk about dyspnea with those with advanced life-limited illness, because not only do we just see that more commonly because that's what we do, this is not what our colleagues think about when they're seeing it. And that's not what a nephrologist, when he hears breathlessness, and you say it's not fluid overload, they don't want to dialyze them, then they sort of look, and it's like, well, that's your field, right? Your symptom management, right? And these things. And I think we're the ones that sort of get projected as the specialists of managing these symptoms, when it isn't a matter of diuresing or a round of dialysis or bumping up the strength of their inhaler. So there are, more specific things you can talk about, cause of dyspnea that works, but I feel like lecture such as management of the COPD patient or end-stage renal patient, and then with them describing dyspnea, is a little bit more high yield to discuss the very specifics for them. But again, treat the underlying disease until you can't. But a few pearls I take away when I see these patients, and I think may have value for you, the attendees, but I think especially for fellows, if you're coming out there and brand new with things. And the first one is, and I found this out, it's like, we have the list of meds that auto-populate from Epic. Doesn't mean they're taking them. Can they afford them? Right now in our cancer clinic, they've changed billing guidelines in the country, and now there's huge copays for some of their chemotherapy. So they're trying to get $2,000 for this month's chemo, and then they turn around and they're like, oh, well, my Symbicort, I'm not sure if that does anything for me anyway. I take it every day, yada, yada. And they go on from that. They stop taking it, and they don't realize over time, no, your Symbicort was doing something for you. Are they using their inhalers properly? So a lot of people, when they first get diagnosed, or they say, well, maybe you need an inhaler or PFT like that, they just show up at their local pharmacy. They maybe get a spacer, they get the thing, they get handed to them. Nobody shows them how to take it, or they were supposed to read the insert. Who reads the insert or things? So ACP used to have a very popular class about people going and just how to teach your patients how to use some of these respiratory devices, because a lot of people don't know how to use them or don't get instruction. Do they have an action plan for these things? They should have an action plan if they're using an inhaler or they have chronic issues that can give them a sensation of breathlessness, let alone respiratory distress. Have they become so frail, or they by themselves, they no longer have the ability to take the meds? Is it somebody with a tremor, they just can't put together the pieces of their inhaler or some other device for them to do it. And they haven't been able to tell somebody, I can't do it together. I'd have a better chance at cracking a safe than I would being able to put my nebulizer together at home. And then I found this commonly, unfortunately, in our field. Did someone stop them when they entered hospice or care facility? So, picture the patient. They went to a standalone ER. Standalone ER said, you're really sick. So they send them to their local hospital. Local hospital says, oh man, you're really sick. We got to bump you up to a tertiary care place. Let's transport you to Detroit. They get to Detroit. They're treating them. They do finally well enough that they go to the SNF. But then at the SNF, they have a discussion. They're not improving. They come in, they get a palliative consult. Someone says, man, I really think you need to go to hospice. So somewhere in that space of time, they've had 5 or 6 stops that somebody either didn't transcribe their inhalers, or they thought they didn't need them, or they presented, and they get home. They find out that the home medicines they were on just a month ago somehow got left off the list. And also sometimes when people are newbie in hospice, depending on who you're supervising, they just do a pan purge of people's meds. And it's like, oh, they just get the rescue kit and something else for symptoms, depending on where you are or the sophistication of your services. Like, no, they need their insulin. They need their inhalers. They need to go back on this. These things didn't stop because they're going home because they're needing dialysis, but they're choosing not to. And I found that a lot more commonly in my career than I would have first expected going in. Are they underdiagnosed? So are you thinking about, our patients that they come to us, but has it been a condition that really hasn't been worked up or thought about? So quite commonly in my clinic, I haven't seen a doctor in 9 years, but then I was having enough chest pressure that I thought I'd better go in. Thought I had a heart attack. It's like, oh no, sir, unfortunately, you have squamous cell carcinoma to the lung and it's pressing up against the rib, and that's why it's hurting, and we think you have it to a brain. They haven't seen anybody for anyone else. They haven't noticed that they've had asthma. It's just not the air, or they don't per se have way out of control hypertension as compared to they just have uncontrolled hypertension for years. And now somebody needs to put them on meds because they haven't seen anybody since they needed suture sometime in the 2010s. So, it's not uncommon for me to have someone come in with some other symptoms and to find out, well, this whole rush to get them worked up for cancer, nobody sat back and taken a look at their primary healthcare needs. I always thought this was a valuable phrase. I learned on it. A penny's worth of cancer can cause a pound's worth of clot. I've explored when I was doing more primary care or when I was a general medical officer in the Navy. Sometimes somebody would come in, they have a DVT with no reason, and we'd look or we'd start to think about it. It's like, well, maybe we should scan you. And it was easier in the military to get something as compared to justifying to insurance. And lo and behold, there'd be a small mass on their pancreas or something. But in our clinic, even if somebody was caught early or some other reason, or they have, they one lump in their breast and we're evaluating it, but then shortness of breath, that's all it takes sometimes for them to be able to have a clot in a place that's not handy. We're now thinking that COPD patients with having exacerbations or severe might be having PEs more often than we realize. That was a journal article I saw in the last 2 months. They used to say this around the homestead at VCU, and I think it's just to help people remember it, but it's just red cells die fast, but not as fast as cancer grows and spreads. So the idea we put behind that is when patients come in and they're saying that suddenly they're feeling fatigued or things aren't going well for them, they used to do a review and see that they need to get a workup to see if they've got metastatic burden increased. And then another thing is we just check their cells. And it was amazing how many people would drop their hemoglobin 3-4 points in a month from either chemo or something else going on or bone marrow invasion. And that's the reason you're tired. Your hemoglobin now is about 6. So just things to see in our patients. Remember that those things can progress a lot faster than you would have maybe thought in other circumstances. Oncology. So again, with their mAbs and their yabba-dabba-do-mab, are those giving pulmonary symptoms? That tends to be a common side effect of many of them. And this is one of my personal crusades. It sort of fits in. I'm wedging it in and I'm hitting it in with a hammer. And that's many patients sent off to rehab on these mAbs never return. And that because they never return, they don't register with the prescriber about how successful they are at any of the burdens. So to give you an example, you have John, Paul, George, and Ringo get put on these. They're told you're too frail for chemotherapy, but we have these immunotherapies, and you can do that, and it'll buy you some months and some symptom burden. You'll do great, but we'll send you off to rehab because you're not strong enough. And John, Paul, George, Ringo go off. John and Paul pass away at rehab or decide to go to hospice at rehab. George and Ringo return. Well, then they remember George and Ringo, and it's just sort of like, oh, it works for everybody. Look, George and Ringo did well, and they forget about John and Paul. Didn't help them out, or they were frail. So this is from a colleague, somebody that I was one of my attendings in fellowship, who is a hem-onc as well as palliative care fellowship. And she wrote an article about this, and I was trying to find the reference. I could probably find the reference later, but I gave up at the top. But she opined that if you're getting these last-ditch meds, these immunotherapy, you should get a hospice consult or an informational, because after these fail, things move quickly, or they may not work. There may not be time, but this is sort of suggesting this is the last turn that we have. And if you do really well on them, great, but at least you can be prepared or not be in the wrong place if these don't work. And an interesting thing, a side study from that about it, these immunotherapies get sort of thrown out there. It's like, they're perfectly fine, or you just take it with a spoonful of sugar, there's no problem. But when they compare them as compared to some chemotherapy regimen, when they had patients describe moderate or severe side effects, 49% described moderate or severe with chemotherapy, 42% with immunotherapy, and immunotherapy had the benefit of less hair loss or cosmesis. So they're not without symptoms, or they're not that they don't have severity, they just made a little bit better. But I think the popular culture out there, as they think of these things, it's like, well, there's no harm, no foul. And that's not the case. There's a lot of side effects. They can shorten somebody's life if they go the wrong way. And they can give people a symptom burden, especially if they give them a pulmonary fibrosis that they don't return from. They're doing education right now. I've seen this in ASCO about what's called the tone effect. And it's normal for us as humans, but I give the best example, about a facetious example in a second. But it's normal for us, for how something's to express, to sometimes take the tone of what is being said as compared to the message. So the facetious example I'm going to say is that if you got a dog, and if you spoke to that dog in a nice tone and said, "You're full of fleas, you drop fur everywhere, you're just a stupid bag of fur that regret getting. Yes, you are." The dog hears that, wags its tail, but he said, "You're the greatest dog ever. We love having you. You're a watchdog that'll never let anything happen to the kids." Well, the dog hears that. So what you're saying is compliments. What they're hearing is something as bad. So it's been discussed now that a lot of the times when we discuss these therapies, especially if we think of these therapies as being somewhat benign, the patient hears it in the tone. And I can be saying, this has a 40% chance of pulmonary fibrosis. This has a chance that it can decrease your white red cell count. It can decrease this, but this is immunotherapy, and this can buy you some time. That really what when patients come out of it, what they hear is more what they project with the meaning or the tone from it, as compared to someone telling them this can have a significant side effect burden. So one of the things that I'm working a lot at with the docs that I work with and spreading is that if we're getting to the point with these patients, they really should meet with me, and we should really talk about, do you have an advance directive? Who do you want to make a decision? What happens if this doesn't work? Because my understanding is there's not too much else in the drawer if it doesn't. So I'm going to take a second to step off of my soapbox, and we'll get back to the rest of it. So scales, again, there's no lab value that directly correlates to degree of dyspnea. So ESAS has it as one of its measures. So now this is an official palliative talk because we've shown an ESAS scale. But you look on all them on there, shortness of breath is only one in a whole field sheet that people have to go through and on the same scale. But I would be very surprised if someone filled in that they were short of breath, that they were otherwise not symptomatic for tiredness, not symptomatic for depression, anxiety, or well-being. Okay, so we'll talk about the Borg, not this Borg, 21st century Borg. This is probably one of the most common scales, and it's a simple scale, but it's been able to, so patients can tell us how they feel, and then when we're treating them, then it's a scale to go back to. So the idea that the patient can either report the number or point the line and say, this is how I think I feel, or describe it. They're allowed to point between the between lines. So they can be 3.5, so to speak. They can be between moderate and somewhat severe. But it's something that's descriptive, turn into a scale, and then treatment, we can use it to compare back and see how the patient is feeling later. There's a lot of these scales around, but the difficulty with, and you'll find it if it's what your institution prefers, but the difficulty is more of them have been in trying to improve upon this, have become more complex, and they're not quite as validated as doing that much better than the good old board. What if we're not talking, or what if the patient's not there? So there's the respiratory distress observation scale. When I was a fellow, every patient who's no longer communicating with us, we had to put this in the note. We had to document how they were doing to back up about whether we thought we were addressing their symptoms well. But this is a way to give you an idea that maybe the patient is having distress when they can't speak anymore, having distress in general. Try and affirm to you about what should you do something, and how well are you doing it. Okay, so we always have to be vigilant about underdiagnosed or undiagnosed conditions, and that includes the failure to obtain treatment. But the large majority of patients we're going to see, it's related to their underlying illness, and everybody's done the best they can, and it's there. So where do we go? So the thing is, it's this poor spiral that these patients will have. So as their dyspnea progresses, you then find that a lot of their other problems progress. And I see that from the patient who otherwise has not been having to talk to social work about things, or make more calls to the nurses, or to even call into me or my partner and say it. But the dyspnea gets up, and then we start getting calls from family. They can't get around as much. Can you sign an order for a scooter? I need to have a break. Is there a service that somebody can come and sit with them for a while because they can't get up and do anything themselves? I have to get up every time they want to have a glass of water, or we have to clear a path now. They have to be able to make the straightest path to get to the bathroom, because it takes them a while and they get stressed out. Big thing in my population is to the point they can't work anymore. They're the sole provider. They live paycheck to paycheck, but they just get to get to where they're repairing cars, and they just cannot bend over long enough to take out a carburetor or lift something. Just loss of freedom, increasing depression. We have the calls, can we help more with mobility? Can somebody come in? Can we get more equipment? Because they have difficulty speaking, or they don't want to speak, or it's harder to have conversations for a while, they get social isolation, more difficult for them to talk on the phone, or they have pauses. When it gets even more severe, it's difficult to eat, or lack the ability to do activities of daily living. When I did hospice visits, people would apologize again and again. It's like, sorry for the state of the house. I would have vacuumed, would have picked up the dog toys, but they just can't get up and get around anymore. Difficulty to eat if they just can't take a break to breathe because they're chewing. Takes enough time. That's very severe in trying to address that. But they have worsening weight loss, or if they have the cachexia of cancer and they lose muscle mass, they just lose that muscular ability to generate air in and out, move that diaphragm, move those intercostals that they were depending on more. Worsening anxiety, worsening depression, and including the great spiritual distress. Why would a loving God do this to me? And then poor sleep. And I'm a big advocate. If you don't sleep well, pain is worse, everything is worse. And then I start finding this cascade with my patients. They say they're breathing well, they can't get comfortable at night to fall asleep well, they wake up gasping, and then I start hearing within a week, they start telling me about their pain regimens not working like it used to either. With worse, so we've done from studies and from out of just one of the palliative care textbooks. I know we're supposed to be journal articles, latest and greatest, but if it's a good fact, it's a good fact. And that's that as they get worsening dyspnea, they have a greater desire to want to end things, or to start saying that they want to die, or what can we do? Is there anything that we're doing to slow it down? Is there anything to speed it up? Start asking you about right to die states, which I've had patients actually do. In fact, one patient this week. And then worsening dyspnea. So at our hospital, probably like your hospital, we're trying to decrease ER visits. And if somebody does come to the ER, try to decrease admissions. And if they come on in, try to get them out. And it's known in sort of the studies, if they're having dyspnea, even if they're on hospice, if you're not getting their breathlessness under control, they're going to come to the ER. And then they're going to be more likely, once they get to the ER, they're going to die in the hospital. Okay. So you suspect they have dyspnea. So the process to follow, again, how are they worked up before and how well managed were they? So they talk about depression and anxiety are correlated to describing dyspnea. So one of the things that sort of gets projected is if this patient has a history of depression and they have a history of anxiety, then you could probably predict they're going to have issues with dyspnea. But however, I worry about the chicken and the egg effect. It's like, oh, well, they're depressed. No, I think they're depressed and they're anxious because they feel like they can't breathe. So I do survey all my patients for depression and anxiety, but I get a little bit more skeptical. That's like they were therefore ordained that they were going to have dyspnea issues. I think that's been confused or muddied that one causes the other, or the famous chicken and the egg. So a little break from it. So the number one most important question for the differential of dyspnea is: are you dating a fighter pilot? Okay, let's say this. So for those of you around, or I should public domain Paramount, from Top Gun, but had the number one song "Take My Breath Away" from the 80s, and you couldn't turn on the radio in the 80s without hearing this again and again. But I put this in not as a little joke, but it was a reminder to me when I was doing the study, something that I talked to my patients about to be able to do complete care, and that's travel on airlines. So commercial airliners can have slightly lower partial pressure in the cabin, or otherwise the oxygen content can actually be a little bit less. And my understanding, talking to a flight surgeon friend of mine, is a consultant for I shouldn't say a major airline. You've probably flown on a major airline, has said that sometimes the content changes. Sometimes it depends on how well they're running the filter. Sometimes how they run things affects the fuel. The engines have to run harder. And as you can imagine, the airlines don't like burning fuel when that costs money. So if you're already having borderline sensations of respiratory distress, or borderline, or you're very sensitive to changes, then you get an environment where the ambient air may be down a little bit, or the pressure is a little bit. You may find that you've come on board and you've now induced like 4 hours of difficulty, or however long your flight is, if it's longer. More admittedly, it might account for the airline blowers, and I'll talk about that a little bit at the end, but why 40, 50 years on, the airliners still have those things. And then even if they're physiologically intact right now, they're borderline and they're not going to take a flight, but you got to consider a little bit, or ask them, if you hear them say something. I live in coastal Carolina. I live in, I live right down a little suburb from Wilmington, North Carolina. I see the sunrise out of the ocean every morning. But I think since I'm not doing well, I'm going to try and see family if I can. I'm going to go see my nephew in Denver. You're going to go to Denver where the air is thinner, and most even healthy people describe going there and they don't feel well. The Colorado Rockies talk about it's an advantage when teams come because the air is a little bit thinner. So sometimes from this travel perspective and seeing it, sometimes we have to educate the patients a little bit more. That may not be the wisest area, that if a baseline on your beach in Wilmington, you already feel like you're having a difficult time catching your breath. Another just logistic issue. I'm going to go visit my son in Boston, and they have O2. Does your son in Boston have the ability to get you O2 tanks? Do you have the ability to write a script up there? Is there a doc up there who'll write a script up there? Massachusetts may not recognize my license if I have to do it. So I think people get used to these things to a point, and then they sort of forget. It's like, well, the supplies are out. About once a year or twice a year, I get a call from somebody who's out of state with one of these scenarios. And they may find someone down there, but at the bare minimum, they didn't anticipate it. They tried to find a doctor, and then that doctor has asked kindly would I fax my note to them to show what's been going on with the patient. Okay, so have you tested them for low oxygen? So oxygen is unlikely to provide benefit if their saturations are in the normal range, but it may provide some benefit if their saturations are low. It may provide a fan effect, again, more later, keeping you in suspense. But it may also provide some placebo, especially for families. So at very end of life in the hospital, and if we say about it, putting a nasal cannula in. So is it maybe helping the patient? I'm not sure, but if it's not bothering them and the family sees we're doing a little bit more, then I think that sort of helps them. And remember, as I went in my first few slides, we treat family. And I don't want anybody to look away and say, well, we didn't do enough. And poor dad, his last couple of days, he felt like he was gasping. He was looking at, he didn't want to talk to anybody because he was afraid he was going to get short of breath. So, I think for putting it in 2 liters and say we're doing it. But this would happen about twice a year at my last institution. Somebody would say, oh, well, we're doing it for just placebo. and they wouldn't turn the O2 on. And then the family would see there was no flow and they were flipping out because how long has dad not been getting the therapy? So if you're going to do it, even for placebo, but turn it on, people are smart enough to look to see that there's no flow in the cannula. Can they get their environment for less requirement for activity? Can they change their living space? Can they live with somebody that's on the first floor? Can they get stuff moved around? Can they have a command post? So can they have a Barco lounger, which has everything they need there, something to hang over the side of the chair. It's got their reading glasses. It's got their book. It's got the remote. It's got batteries for the remote. They've got a table by the side. It's got a drink. It's got a big jug of water. They don't have to go refill it. And even if getting up to do things are well or necessary, do you need to put a sign on the door that says, don't bother ringing the doorbell? Do you need to put a sign on the door that says, if you need something, please call this or tell it? And then sometimes to the point, sometimes people, they just can't get to the bathroom in time, and then they feel embarrassed. They've soiled themselves, or sometimes they'd rather, between the choices compared to feeling that dyspneic or feeling ill by having to do it, sometimes they will soil themselves. Then you have caretaker distress if they come home and they've got it, or they were gone for just 20 minutes to go do something in the yard, and then now they've got to clean up dad there. So do they need a bedside commode by the chair? Do they need something else to shorten the distance to the bathroom that they have to get up and transfer to go? And then is their nutrition optimal? Are they not eating as much because they haven't been, it's a little bit more difficult to breathe? Again, we want to try and present some of that muscle loss because that's just going to cycle in and become a bad feedback loop into making it even more difficult for them to breathe and therefore have the sensation of breathlessness. All right, so I've seen this across, so I'm just going to say controversy. Some sources will say, oh, if the patient describes chest tightness, it's probably linked to this, and therefore if you address that pathophysiology a little bit more, you're doing better. Then I can flip over to another paper that said doesn't make any difference. Chest tightness is subjective. It could be linked to 5 different things. Trying to justify doing one specific thing because it's targeted to that one thing, you just, maybe just shooting into the fog. So just to say, if something works for you, it works for you, but a little bit more emphasis has been played that X symptom must equal Y treatment may not be borne out depending on some people's literature. So you just have to take that with a little bit of skepticism when you do it. If you see it yourself, then you see it yourself. Oh, okay. When is it time for the medication? So if anxiety is thought to be a component, then benzodiazepines may help. However, they're thought to be of limited benefit with anxiety. So when I started in medicine, there was the thought, because, we know that the danger is if you mix a benzodiazepine with an opioid, then you increase their risk of a respiratory depression. And then the thought was, well, opioids increase your risk of respiratory depression. Opioids help with the sensation of breathlessness or dyspnea. Therefore, the same mechanism works for benzodiazepines. Turns out it's not true. That if benzodiazepines alone, if the patient doesn't have an underlying anxiety, do not tend to do that much for giving them that same benefit of relief. Outside, of course, we're talking about the very extreme end, which is palliative sedation. What about other medications for anxiety? Well, benzodiazepines are indicated for anxiety, and they have a wonderful effect, especially the idea of the pill in the pocket. That if a patient knows they have something they can take if they're anxious, sometimes just knowing they have something will prevent it. However, when the research was done and benzodiazepines were written as a standard for anxiety, it was in 80s and 90s, and it's still valid. But it was before the advent of SSRIs, SNRIs. In fact, 2 of them, when they got their major indications, was a year before fluoxetine came out. So most of the SSRIs, SNRIs, they will treat anxiety, and they will treat it chronically. Or you can think of buspirone for anxiety or something else. So if this patient tells you they're having anxiety every day, instead of worrying about the downside of benzodiazepines, especially if you think you're going to have to prescribe opioids as well to help with their breathlessness, get them on a medicine that's more indicated for the chronic anxiety. It is unlikely that this is going to hurt anything, especially if you get them on one of the 2 that are also validated for pain. But if they're having anxiety that often, then they should be on a chronic medicine for it instead of something episodic, or choose the medicine that has a far less likely interaction with opioids, which they'll probably need for their breathlessness. So the example that I give to my medical students, just to remember that, in the 50s, when we didn't have much for lupus, they did studies, and aspirin, grams of aspirin were indicated for lupus. And you can still find that aspirin is considered a medication for lupus, but I don't think you find too many rheumatologists prescribing that as compared to steroids or DMARD or something. So you can look up benzodiazepines and say, yeah, that you could use them for anxiety, the same way that you can look up that aspirin is indicated for lupus. So I'm trying to launch people over on this. Think about if they're going to have a condition that the anxiety is going to be daily, then you should think about something that's meant to act daily or chronically. Mucolytics, the secretions are causing cough. So a lot of the mucolytics, we used to think they were cough suppressants. It turns out they're probably not. But if they break up the secretions, if they make them slicker, or things like that, then the effort that they have to do to cough them clearer is less, or the force, and that may stop them from going into a coughing attack or spell that subsequently spirals into a sensation where they're feeling like they're dyspneic. Also specific modalities, and as I said a little bit earlier, if we're having to talk about management of the COPD patient, then we could go a little bit more. But just example, XRT, superior vena cava syndrome, they have pre-existing COPD, steroids might help, non-invasive ventilation. But my personal note, if someone's coming in the hospital, we're talking about putting them on high flow, like 45 liters of oxygen or vapotherm or one of these other stuff, or even we're talking about, do you want to be intubated? It's time to really have the discussion of what you want, because what happens if we get on high flow nasal cannula and we can't get them off? So I think that as best as you can, if you can have a goal, the goals of care, it's like, well, what if we do one of these therapies and we find that we have a hard time weaning you from it? Have you thought about that and the component of starting one? Okay, so just give me 1 second here until I do my product placement. Okay, so I'm a big fan. So there's significant evidence that blowing cool air towards the face helps the sensation of dyspnea. The process is thought to be a reflex of the trigeminal nerve. Handheld fans are popular these days. There's a study that found one of those little handheld fans that they sell at the amusement park or the sport, Lions Stadium. Actually, when the patient has that and they know they can do and sit that, they get a relief. It actually cuts down their anxiety. It has sort of the pill in the pocket effect. So reduce it, but it does help. So remember I said about the airlines and those blowers, they think that, airline passengers, I said that's a good thing, or I feel killer. But there might also be that it makes them feel a little bit better if there is a little bit of difference of pressure in the plane or other things when they're going on. And that's why they've been kept, or that's still a staple in the airlines, to have that thing and to open it up wide open. And again, so again, this is told to me, I've had patients say that they got on a plane, they had some difficulty beyond feeling this way. And then again, somebody I know that consults for an airline, the flight surgeon's one that told me this is what's going on in the cabin and sort of suggests that. So it's a cool room. So hot air does not have the effect. It's coolness hitting the trigeminal that does it. So if you had a little blower, there's fans that actually can maybe throw a mist as well, might be it. Some places, so a friend who practices in Arizona, that if you tell the HVAC company you have certain lung conditions, they as a courtesy will prioritize you to the top to come out and fix your air conditioning because it's a medical device. So cool, dry air is how it works. The more hot the air is, the more humid the air is, the harder it is to breathe. You're sucking more mass through. So a friend who's a pulmonologist, a Navy pulmonologist at Camp Lejeune, which is on the coast of North Carolina, had patients that had some difficulty breathing. They had some COPD, and he'd say, but they didn't want to run their air conditioner, or they save money, or they're having difficulty do it. But just running the air conditioner, cooling the air and sucking that water mass out of the air that's a little bit drier and to go through, that in of itself changed the effort they were having to do to breathe and made things easier. And, I said I did this, telling John a little bit before I started this talk, that I gave this talk to colleagues in Texas. That's a big problem for them, that there's a form of air conditioning out there that depends on blowing humidity around. And therefore they can't get air conditioning in to patients to counteract that, because it makes the air more dense, because they are blowing a form of humidity into the air. So what's your position on the subject. If you COPD, putting yourself forward and bracing themselves, sometimes that can break it. They can recruit better their intercostals and their neck muscles. Pursing lips or teach them to recruit the diaphragm. Behavioral therapy to calm down or cut off the positive feedback cycle. Or just would pulmonary rehab help? Can you get them a consult to go, can they get them some tricks, or can they re-strengthen up other secondary muscle groups? Opioids are the mainstay. You usually start at lower doses than you would for pain. If already on opioids for pain and still having dyspnea, this is a non-scientific rule of thumb, but I hear people bouncing around. You'll hear it in your career. It's up to you to decide what you want to do. But they say their pain's controlled, but they still have dyspnea. Well, how much more? Some have suggested a 30% increase is usually what they may need to get a relief for dyspnea. But I cannot find any science behind that. I have a little story behind that, but I know I'm running behind because we had the technical error on my end. So I'm just going to go through. Codeine and morphine are the most studied. You can go, I'm not a fan of codeine though. You can go as low as 5 milligrams. So I read an article and it just said, hey, you know, what dose do you use? It's like, well, the usual, you know, and they said blah, blah, blah. And that's like, well, that's different than 6 other articles I wrote that says the usual. So I apologize. I didn't put a bunch of dosing regimens in here because if I could have found 2 articles that agreed, I would have, but they don't. So you have to your institution. But be aware, it usually does take a lower amount as compared to if you were starting an opioid for pain. We're not sure if methadone gives that much benefit of all the great things methadone does. Could not find much on buprenorphine. And I just said, you know, opioids help with dyspnea and benzos lower your respiratory drive, but they don't seem to help with dyspnea. But so here I am applying a rule without any science, but maybe buprenorphine doesn't help that much because what's the joy of buprenorphine? It's not as much of a risk to your respiratory drive. Usually, again, you start less of a starting dose than one would for pain. There seems to be some benefit for promethazine by itself, or promethazine tends to be sort of a false multiplier or may increase the efficiency of the opioids that you're giving for dyspnea. Here, for the sake of time, you can read this slide, you have it, but all the different ways that opioids help, but they probably, as in some ways, as compared to the other ones or the benzodiazepines not helping, probably there's an area in the brain they touch that the benzodiazepines do not. Palliative sedation. So when all other measures fail, but you have to be very careful about documenting what you've tried. You got to be very careful talking to the patient and the family about what's it mean. There really should be an idea of respite sedation about we're going to stop and see if you come out of it. Do you still have the same sensation of breathlessness and a protocol? And again, I can't type person place, but I just remember being at a conference in Lubbock. The 3 most common reasons that palliative doctors get sued. One, in all their travels, but you know, those 5 stops before they end up in hospice, it got lost off the chart that they had an allergy. The second was we didn't address pain properly. Part of that was didn't feel like their pain was being addressed, but part of it was like, oh, well, this Tylenol 3 didn't work. I'll put them on 100 of OxyContin 3 times a day. By some of our colleagues, you may not have the benefit of the training that we have. But the third one was things around palliative sedation. And the number one was, had you documented well that you had exhausted all other options before this was offered? There are a lot. Michigan, I'm still new here in the States, I won't say it, but I can tell you, Texas was very hyper vigilant about palliative sedation as what's the difference between that and euthanasia. At the governmental level, at a lot of grassroots level, they're very vigilant about that. And we had to be very careful about what we were doing and saying we had tried everything and the patient and the family was informed. So that's it. In the spirit of alleviating suffering, I'm going to end. I'm sorry that the talk got interrupted. I don't think you missed too much. A few of you may have been sedated by this talk. So I don't know if we have time for questions or we should jump in. I don't want to take away from the fellow. You can always email me. And then I had this slide set, so some of my citations are at the top. I couldn't get PowerPoint to put at the bottom. And then these are some other citations that didn't fit as well as the book or references. So I'll end it there.